Before I introduce our speaker, I do want to give a special thanks to the Dietitians and Nutrition Support DPG, whose grant funding for this initiative has made it possible for us even to be here and have this webinar in the first place. So thanks to them and the great work that they're doing. But today I'm elated to have Shane Robinson with us to speak on a topic that I think is pretty integral to what we do in our clinics, which is estimating calories, protein needs, and fluid requirements in people with ALS. She'll give her presentation after I introduce her briefly, and then hopefully we'll have a few minutes for discussion and questions at the end. But do also want to remind you guys that this is being recorded, just in case you are not aware. So our speaker today is Shane Robinson. Shane is an outpatient clinical nutritionist for the ALS, cardiothoracic surgery, and the heart failure virtual visit program at New York Presbyterian, Columbia University Irving Medical Center. Shane is also the dietetic internship coordinator at Florida International University. I have no idea how she does all of those roles. Being in academia, I know how much even that dietetic internship coordinator position probably takes. She joined New York Presbyterian in 2013 after working as an oncology dietitian at the Beth Israel and St. Vincent's Comprehensive Cancer Centers. She transferred from New York Presbyterian Weill Cornell as an outpatient oncology clinical nutritionist to New York Presbyterian Columbia in 2017. She completed her dietetic internship at New York Institute of Technology in 1997. She has her BS in dietetics from University of Maryland, College Park, and then received her master's in clinical nutrition from New York Institute of Technology in 2022. She's co-authored textbook chapters, published articles, lectured extensively in oncology nutrition, and dedicated her career to clinical care for complex patients and nutrition education for health professionals and the public. So Shane, thank you for speaking with us today. We look forward to hearing from you.
Thank you, Dr. Pearson, for the introduction. So as Dr. Pearson told us, I am going to talk about estimating nutrition needs in ALS patients. Okay, and so here's our agenda for today. First, we're going to talk about why we estimate needs. We'll move on to talk about the factors that influence needs. We'll talk specifically about calories, protein, and fluid, and then I do have to touch on pressure ulcers at the end. So it's especially important that we accurately estimate our needs in our ALS patients because there's such a high prevalence of malnutrition. And in some studies, they estimate the prevalence to be anywhere between 16 to 50% of ALS patients are malnourished. Often our ALS patients have a decreased intake, an increase in energy expenditure, and the deficit can exacerbate disease progression by accelerating muscle catabolism. Excessive energy intake in our patients can increase carbon dioxide production and ventilatory demand, worsening respiratory function. Compromised nutrition status decreases survival, and I'm going to go into a little more details in the upcoming slides. We also know that enteral feeding can maintain BMI and body weight, and according to the American Academy of Neurology, enteral feeding should be considered a therapy that increases survival, although not all studies agree on this. But because we so frequently use enteral feeding in this population, accurately estimating the calorie needs becomes paramount. And so weight loss is a predictor of survival in ALS patients. And for each 5% decrease in body weight, there's a 30% increase in the risk of death. Or also they say for each BMI unit lost from the usual BMI, there is a 20% increase in the risk of death. And so this is our survival curve. And in this study, they've divided the patients into those that have had a 5% weight loss or less at diagnosis versus those that have had a 5% weight loss or more. And you're looking at survival probability versus time since diagnosis. And as you can see, our top curve, the patients with less weight loss had longer survival. So next, we're going to look at factors that influence our patients' needs. It is well known that ALS patients struggle to meet their calorie and protein needs. There are two studies that compare energy intake in ALS patients to the RDA. Now, we do have to consider that the RDA is the average daily level of intake sufficient to meet the nutrient needs of 97 to 98% of the healthy individuals. And ALS is a disease state, not a healthy population. and ALS patients' needs may differ from the RDA. One of these studies found 70% of ALS patients had an intake below the RDA, and the other study found that 95% of ALS patients' intake was below the RDA. There was another study that looked at average oral energy intake of ALS patients, and they were looking at these patients 50 months before death, and they found on average ALS patients take 21 calories per kilogram of body weight. And as you guys probably already know, this is far below what we suggest for this population. Even enterally fed ALS patients can fall short of meeting needs. One study compared enteral intake in vented patients to calorie needs as estimated by the Harris-Benedict equation, and they found that intake was below projected needs. Now, the cause for poor intake is multifactorial and includes, but is not limited to, dysphagia, difficulty chewing. We see a lot of fatigue in this population, and respiratory compromise, which decreases intake, can increase risk of choking, but also increases needs. We see loss of upper limb dexterity, which leads to an inability to feed self, and needing to be fed just adds one more barrier to intake. It also can lead to decreased access to food. We also need to consider food insecurity, since ALS care is expensive and labor intensive, and we all know food costs are going up in this country. ALS patients can also have a decrease in appetite from psychological distress, depression. We also see patients self-restricting fluids because they have mobility issues and therefore need assistance to relieve themselves. And the patients always tell me, less in, less out. If they don't drink that much, then they don't have to worry about their caregiver running them to the bathroom as often. We see polypharmacy with the multiple medications these patients are taking. And we also see a difficulty with a bad taste in their mouths, especially with some of the new ALS medications. And we find that that taste in their mouth can influence intake. We see constipation, but we see lots of constipation, and constipation can kill the appetite. And we also see saliva problems in this population, which can interfere with intake. We also know that there's a dysregulation of energy homeostasis in ALS. We do have evidence of abnormal glucose and fat metabolism, and there are many proposed mechanisms, and the complexities of the metabolic alterations of ALS are not fully understood and outside the scope of my talk today, but nonetheless must be acknowledged. So there are factors in our patients that increase and decrease calorie expenditure. ALS itself leads to skeletal muscle atrophy. And since the muscles are some of the bigger metabolically active parts of the body, at least more so than the fat mass, this suggests that there would be a theoretical decline in energy and protein needs. We also see a decrease in physical activity, which also would decrease energy expenditure. In our ventilated patients, the vent does some or all of the work of breathing, which also decreases calorie expenditure. But we also see factors that increase needs, such as the metabolic changes and hypermetabolism we see in ALS. Hypermetabolism has been described in our non-ventilated ALS patients, and they say it could be attributed to the increase in the respiratory work from the weakened respiratory muscles. So this is a study on hypermetabolism in ALS, and this study measured resting energy expenditure through indirect calorimetry in 62 patients with ALS, and then it looked at factors that correlated with the metabolic load. The REE was measured several times in each patient to increase accuracy, and they found that the measured REE of the ALS patients was about 10% greater than that of the healthy population. And 67% of ALS patients had a metabolic level more than 10% above what was predicted by Harris-Benedict equation. Fascillation, spasticity, or both have been hypothesized to play a role in hypermetabolism because they can increase muscle tone, which should contribute to an increase in the resting energy expenditure. Yet this study did not find a correlation. Resting energy expenditure is correlated with fat-free mass. So considering that our patients' weights are lower and their fat-free mass is lower, one would expect overall hypometabolism, or at least normal metabolism. So this finding of an inverse result suggests the need to look for other unexpected factors that correlate with resting energy expenditure. This is a similar study, a little bit larger sample size. They had 287 patients, 75 controls, same design as the previous study. And what they found is that the metabolic level was higher in ALS patients, that they consumed around 1,500 calories per 24 hours versus the control group, which consumed around 1,230 calories in 24 hours. They found that more than half of the ALS patients were hypermetabolic versus 13% of controls. I also said earlier that using respiratory equipment affects resting energy expenditure. So this study showed that vented patients have decreased calorie needs. The subjects in the study were 16 ALS patients with diaphragmatic dysfunction, and they used indirect calorimetry to measure the resting energy expenditure during the patients when they were breathing spontaneously, and then in comparison to when they were on NIV, when they were on non-invasive ventilation. And the measurements were taken during the patient's first 3 months of using non-invasive ventilation. The measured values were then compared with the predicted values using the Harris-Benedict equation. And what they found was that NIV reduced energy expenditure. The median RE using the NIV was around 1,149 calories for 24 hours, which was lower than the RE during spontaneous breathing, which was 1,197 calories in 24 hours. The mean difference here was 7%. So we have established that ALS patients have a decrease in food intake, which creates an energy deficit and weight loss, but we also see decreased physical activity, atrophy of the highest energy consuming tissue of the body, and at times we even see that we're supplementing energy expenditure with respiratory equipment. So we have this picture of decreased intake with what we would think are decreased needs, yet hypermetabolism resulting in weight loss and malnutrition. The coexistence of these two oppositional processes, or paradox, is a challenge for understanding the disease and estimating needs in our ALS patients. So now I'm going to move on to talk a little more specifically about calories, protein, and fluid, and I'm going to start with calorie needs. So when estimating calorie needs, we really have to first consider our goals. The European Society for Parenteral and Enteral Nutrition Guidelines on Clinical Nutrition and Neurology suggests that if ALS patients have a BMI of under 25, we should be aiming for weight gain. If the BMI is 25 to 35, then we should be aiming to keep the weight stable. And they recommend in BMIs over 35, weight loss to improve mobilization. So if we're aiming for weight gain, we need to go above predicted needs and provide for weight gain and vice versa. Now, there are a bunch of resources to help us estimate needs. There are some published papers that make recommendations based on research, but you really need to look at the references on these papers. And I'm going to show you one paper that the data they used to support their recommendations wasn't based on patients in ALS. We also know that indirect calorimetry is a measurement of energy expenditure and the most accurate method of estimating needs. But this is not a measurement that's available in our typical ALS clinic visit. We also have predictive equations, and then ESPN, which is the European Society for Enteral and Parenteral Nutrition, has also published guidelines. So this is one of the studies that gives some guidelines, but when you look at the references, they're not basing these recommendations on ALS. They're basing them on general guidelines. So this article recommends 1 to 1.2 grams of protein per kilogram, with 70% of the protein coming from high biological value proteins. But this is based off the general recommendations from the Brazilian Society of Food and Nutrition. And when you look, they state that the purpose of those guidelines is to promote the health and well-being of people, families, communities, and the whole Brazilian population, now in the future. So it's not specifically for illness. If you look at the reference for the fat recommendations in this paper, they're based off the cardiology research. So when you're reading articles on guidelines, you really want to look at the references to see where these recommendations come from. Indirect calorimetry is a measurement of resting energy expenditure. So the number or measurement really only measures resting energy. So it doesn't consider energy used in any activity or energy used to digest and absorb food, which we know is the thermic effect of food. You also have to account for energy spent with these activity factors and injury factors. And these things can vary patient to patient. The other limitation of the REE is it only tells us resting energy expenditure in the moment it is measured, like blood pressure. So it doesn't account for variations over the course of the day. So this is kind of like a snapshot or a photograph, or maybe for some of you, it would be an Instagram post. It really only tells us the measurement at the time of measurement, but serial measurements can be more valuable in estimating needs. And you can see in some of these trials, they do serial measurements. Indirect calorimetry requires specialized equipment, and not everybody has access to this equipment. It requires trained personnel, and it is time consuming. As I said, also, this is typically not available in the clinic setting, and we most often see this in the ICU and in research settings. So these are some of the predictive equations we use to estimate calorie needs, and there are some articles that compare these equations, which I'll go into in a minute. Studies have shown ALS patients' needs are on average about 14 to 20% above what's predicted by Harris-Benedict. There is also the Mifflin-St. Jeor equation, the Arett-Jones. Some people use straight calories per kilogram. And there is one study that compared multiple equations and did conclude that Harris-Benedict and Mifflin-St. Jeor equations are the best choices. And then there's also this Kaczarskis equation, and this uses 6 of the components or the questions of the ALS FRS along with Harris-Benedict. Now I give you the equation here, but the online calculator is far more easy to use. And you can see here, this is the website for the online calculator. Eastman also published guidelines on estimating energy needs in ALS patients as part of their guidelines in neurology. And this guideline will analyze the current data in ALS, and this one was published in 2018. And they state that energy requirements in non-ventilated ALS patients should be estimated if indirect calorimetry is not available. They say the estimation should be based on approximately 30 calories per kilogram of body weight, depending on physical activity, and should be adapted to weight and body composition evolution. And they had a strong or 100% agreement and gave a strong consensus on this statement. These guidelines are based on a few different studies. All of them are in ALS patients. The first one was published in JPEN in 2004, and it looked at 34 ALS patients, and they compared measured calorie expenditure through indirect calorimetry to predictive equations in patients with different stages of ALS. And they showed that resting energy expenditure by the Harris-Benedict equation is not valid in compared to indirect calorimetry. And that, of course, takes us back to the recommendation of why they suggest indirect calorimetry first if available. This study found that estimates were anywhere from 677 calories below to 591 calories above the measured resting energy expenditure, which they concluded would lead to under or overfeeding in the majority of patients. They called the equation unsatisfactory for clinical use. They postulate the differences may be caused by several factors, including changes in metabolism from ALS or from malnutrition or changes in body composition. There are 2 other studies that are in agreement with this first study. The American Journal of Clinical Nutrition in 2014 published a trial that looked at daily energy expenditure using doubly labeled water in 80 ALS patients, where measurements were taken every 4 months for a year. And the measurements were compared to 4 different predictive equations, the Rosenbaum, the Harris-Benedict, the Mifflin-St. Jeor, and the Owen. And they concluded that there was a large variation in total energy expenditure. The Journal of the American Dietetic Association in 2011 published a study of 56 ALS patients that compared indirect calorimetry to Harris-Benedict, Mifflin-St. Jeor, and Arett-Jones. And they found that Harris-Benedict and Mifflin-St. Jeor provided clinically acceptable estimates of REE, and that Arett-Jones overestimated the resting energy expenditure. There are studies that suggest relying on fat-free mass and estimate ALS patients to need around 34 calories per kilogram of body weight in patients breathing spontaneously, but in clinic, we don't necessarily have a number for that fat-free mass. So you can see when equations are compared to measurements, there's a bigger margin for error, as we would expect, but they did come up with this number of 30 calories per kilo. Eastman also gives guidance on patients in non-invasive ventilation. And we already discussed that study earlier that showed that patients on non-invasive ventilation have a reduced REE by about 7%. 2 other studies showed similar results in REE from NIV. There were a couple more studies that looked at REE. One looked at 5 patients in comparison to predictive equations. They showed that their measured REE was 33.6% lower than estimated by predictive equations. And then there was a Japanese study that also found a reduced measured REE in 11 vented patients as compared to the REE as estimated by Harris-Benedict. In contrast with these studies, there was a study that showed a higher measured REE than was predicted by Harris-Benedict. This one looked at 18 patients on mechanical ventilation. This one hypothesized that these results were due to higher cytokine secretion and more fusillations or refeeding syndrome. Also, in contrast, another study measured TEE by doubly labeled water in 10 bedridden Japanese ALS patients who were under 24-hour tracheostomy positive pressure ventilation, and they reported that needs were similar to that of non-vented patients. The Eastman conclusion is that non-invasive ventilation is generally associated with a lower REE than spontaneous breathing or predicted by Harris-Benedict. In the absence of indirect calorimetry, they recommend requirements should be estimated between 25 to 30 calories per kilogram of body weight a day or using the Harris-Benedict equation. And their consensus was a little lower on this one. They were in 95% agreement, but they did state the degree was a strong consensus. And so there are many things we have to consider when we estimate needs. We also know all predictive equations use body weight. So it's really important to get an accurate body weight, but we also know how difficult this can be in a mobile patient. It's important to make good use of chair scales, or I often have our staff weigh the patient's wheelchair while the patient is still able to transfer. Then I take a sticker and put it on the wheelchair with the weight of the chair, and we add the wheelchair weight to the electronic medical record. What's most important is that we have to acknowledge that predictive equations are exactly what they say they are. They predict, so they're a little bit like the weatherman, but they're not measuring, and they should only be used as a starting point. Weight should be monitored, and diet or enteral feeds need to be adjusted to meet the patient's needs. Now, this may not wait for the every 3 to 4 month clinical visit, especially in a patient that's new to tube feeding. So interim RD visits are helpful, and this is where we found telehealth very helpful in our population. You can also look at the velocity of weight loss in these patients. So we estimate that 3,500 calories equals 1 pound. So if a patient's losing a pound a week, we can estimate that they have about a 500 calorie a day deficit, and we can use the rate of weight loss to estimate the caloric deficit and then predict the amount we need to supplement. So let's review and draw some conclusions on these many studies we just suggested on calorie needs. The Harris-Benedict and Mifflin-St. Jean equations are the best choices for predictive equations when indirect calorimetry is not available. Energy equations have an expected margin of error. Vented patients probably need less than our non-vented patients, as the vent is doing some of the work of breathing and offsetting some of the calories spent. Current thinking supports at least an additional 10% increase in calories beyond resting energy expenditure values. And what we have to remember is that REE does not include energy expenditure associated with physical activity and or the thermic effect of food. Additionally, we have this Kaczmarski's equation, which looks like another good option. This one is the one that uses the ALS FRS with Harris-Benedict and has the online calculator, and this one's been validated in a clinical trial. The Eastman guidelines suggest approximately 30 calories per kilogram, but really what comes down to, and what's most important, is that we monitor these patients closely and adjust as needed, especially when using a predictive equation, because these equations are really only our starting points. Okay, so I'm going to move on and talk about protein needs. And there's even less data on protein needs. Considering the lack of physical activity and muscle wasting from the neurologic damage, we would think protein needs to be pretty high. Easton concluded that there is insufficient data to perform any recommendations on protein requirements for ALS patients, and that common determining factors should be considered, such as age, kidney function, and degree of stress. The Aspen core curriculum suggests that current practice dictates that energy goals should meet demands and that protein intake should be at least 1.5 grams of protein per kilo per day. So since there's so little on ALS, I wanted to start to look at other disease states that I thought might be similar, or at least might have similar protein requirements. And since people with spinal cord injury tend to be pretty immobile, I thought that was a good place to start. So I was looking at the Nutrition Care Manual of the Academy of Nutrition and Dietetics, and they recommend for a person with spinal cord injury, 0.8 to 1 gram protein per kilogram body weight per day for maintenance, with an increase to 1 to 1.5 grams of protein per kilogram of body weight if there are pressure ulcers or if the patient has an infection. I thought the 0.8 to 1 sounded a little on the low side to me. So I also looked at the guidelines on Duchenne's muscular dystrophy. This is another lethal, progressive neuromuscular disorder, but metabolically it can be hypometabolic. And it's typically in a younger population, and most studies considered the needs for growth, and there were no published guidelines on protein needs. So I'm going to move on to fluid needs. So there are a lot of factors that affect fluid intake. Dysphagia and the need for thickened liquids, which are less appealing, tend to decrease fluid intake. Reduced mobility and dependence on caregivers tends to make patients fearful of drinking because it requires extra trips to the restroom, and some of the patients have fear of incontinence. Some of our patients, especially in the ones that have FTD, have poor decisional capacity due to cognitive impairment, and a lot of our patients just don't have the appetite to drink enough fluid. We know that physical and cognitive impairment can result in as little as a 2% decrease in body weight due to dehydration. And so there are two good studies that looked at hydration in ALS patients. The first study used doubly labeled water, and this was a multi-center study conducted over 48 weeks. They looked at 80 ALS patients, and they did 250 individual measurements with the doubly labeled water. These results were then compared to age and gender matched healthy controls. And doubly labeled water is the gold standard for measuring hydration. But this test is not available in our typical ALS clinic. So the second study used urine-specific gravity, and they used the same data set. Both studies concluded with a predictive equation, which I have coming up. But I just want to go through some of the other very interesting conclusions that they drew from this study. So they did conclude that median survival from first clinic visit was almost twofold longer in patients with water intakes above 2.88 liters per day. After adjusting for age, bulbar site of onset, FBC, and BMI, water intake still had a significant effect on survival. And they found that lower water intake actually had a greater negative impact on survival than BMI. And so these are the equations that were evaluated. And some of the equations evaluated overestimated needs, and others, such as our typical 1 milliliter per calorie per day and the Holiday-Seeger method, underestimated needs. They concluded the best choice was this equation based off the Kosarskas equation, and I have it highlighted here in red. So to conclude on fluid, we can assess fluid needs by calculating the calorie needs using the Kosarskas equation, and hint, hint, that online calculator is a lot easier than doing the numbers. And then we can use this next equation down here in red to determine fluid needs. These equations, like the calorie equations, are just a starting point, and we need to monitor hydration in our ALS patients. Fortunately, we have many ways to monitor hydration, such as skin turgor, weight fluctuations, dry mouth, thirst, urine output. And I often ask the patients to tell me, is your urine dark and thick? How many times a day do you urinate? Are you urinating normal volumes? And in some of our patients, we have blood work available, which can tell us a little bit about hydration status. Lastly, let's talk about pressure ulcers, since our ALS patients are at high risk for pressure ulcers, and we do see pressure ulcers in our clinic setting. So the European Pressure Ulcer Advisory Panel and the National Pressure Injury Advisory Panel and the Pan-Pacific Pressure Injury Allowance recommendation for pressure ulcers is to provide 30 to 35 calories per kilogram of body weight per day for adults with pressure injury who are malnourished or at risk for malnutrition. And in terms of protein for pressure ulcers, same group recommends 1.25 to 1.5 grams of protein per kilogram of body weight per day. And for patients with stage 3 and 4 pressure injury, the proposed amount of protein is 1.5 to 2 grams, depending on the size of the pressure ulcer and the total protein loss from the draining wounds. So to conclude, it's important to accurately estimate needs because nutrition status influences survival and patients are often enterally fed. There is an altered metabolism in ALS and a paradox, which makes it very difficult to predict needs. Indirect calorimetry is the most accurate method of predicting need, and in its absence, we do use predictive equations, but only as a starting point. Accurate monitoring of weight is essential to adjust patients' intake based on their weight changes. And we know needs are lower when respiratory support is provided and higher when pressure ulcers are present. And I'm going to just run through my references slides. There are quite a few references. Thank you for your time today.
All right, thank you